First described by Baumann in 1849, Moran's ulcer is a painful, progressive, and chronic ulcerative keratitis that begins peripherally and progresses circumferentially as well as centrally. It is an idiopathic disease occurring in the absence of scleritis or any diagnosable systemic disorder that could be responsible for the progressive destruction of the cornea. In view of the possible autoimmune etiology, corticosteroids and immunosuppressants form the mainstay of medical management of this condition. Moran's ulcer can occur in all age groups, but the vast majority of them present between 40 and 70 years of age. Hence, they often are associated with cataract, which may affect their visual acuity even after successful control of inflammation. It may be associated with posterior capsular opacification, which may be secondary to chronic inflammation or corticosteroid use. Cataract surgery in these patients is technically challenging due to the extensive peripheral thinning and the effects of chronic inflammation. Also, as corneal stroma is the target of destruction, severe inflammation can be precipitated by the cataract surgery. There are reports in literature of elective extracapsular cataract extraction via limbal incision and phacoemulsification through a scleral tunnel being used to overcome these difficulties. Hence, it is of paramount importance to individualize the cataract surgery depending upon the patient's presentation. A 50-year-old known diabetic male was referred to us for right eye cataract surgery. He was a known case of bilateral Moran's ulcer and had undergone 360-degree conjunctival resection with cyanoacrylate glue in both eyes 2 years back. The right eye was quiescent with a mature brown cataract. Over the years, the left eye had undergone multiple surgeries for Moran's ulcer, including a tectonic sclerocorneal penetrating keratoplasty combined with an extracapsular cataract extraction and an iris claw intraocular lens. Though his inflammation was well controlled in both eyes when he presented to us, he had poor vision in his left eye, rendering him practically one-eyed. The challenges that we faced while managing this case were a greater than 270-degree peripheral corneal thinning, sparing the inaccessible superonasal quadrant of the right eye, which has the potential to pose technical difficulty in wound creation and instrument manipulation, a hard and brunescent cataract, scleral thinning, and a poor visual outcome in the left eye following a combined corneal and cataract surgery. However, he had some favoring factors in terms of an inactive quiescent eye, a healthy endothelium, and a relatively healthy retina based on B-scan. Considering this, we decided to go for a micro-incision cataract surgery with intraocular lens implantation under guarded visual prognosis with a customized approach which included perioperative medical management and modification of surgical technique. Complete control of inflammation is of utmost importance as an inactive eye facilitates uneventful surgery and is less vulnerable to post-operative inflammation. In this patient, we achieved perioperative control of inflammation by using steroids and immunosuppressants as per an immunologist's opinion. Being the right eye with healthy peripheral cornea present only at the superonasal quadrant, patient is asked to lie down with his head turned slightly to the left. The surgeon sits on the left side of the patient so as to approach the eye over the nasal bridge in the superonasal quadrant. As there is a risk of scleral necrosis post-cataract surgery in this particular patient, scleral and limbal incisions are avoided. A 2.8 mm clear corneal incision is made through the healthy remnant superonasal cornea. Brown and mature cataract precludes a good fundal glow. Hence, for better visualization, capsule is stained under the cover of an air bubble. The air bubble protects the endothelium from getting stained. A side port is made just proximal to the nasal limit of the corneal thinning. A dispersive type of ophthalmic viscosurgical device is used to deepen the anterior chamber and a continuous curvilinear capsulorhexis is performed. A gentle but optimum hydrodissection is performed next. The phacoemulsification machine is set to low flow phacoemulsification parameters. An in situ direct vertical chop technique is used, which is of great value when the nucleus is hard, as it uses mechanical forces to disassemble the nucleus so that less ultrasound power is required to emulsify it, thereby minimizing the damage to the endothelium. Using the torsional mode with the intelligent phacoemulsification software further reduces the ultrasound power required and enhances the efficacy and safety of the procedure. Bimanual aspiration of the cortical matter is performed with irrigation through the main port, as there was no pathology-free cornea for a second side port. A thorough cortical cleanup is done. A foldable, multi-piece, acrylic, monofocal intraocular lens is implanted in the bag. Meticulous aspiration of the viscoelastic is done, and the surgery is completed by hydrating the corneal wounds. In summary, the surgical modifications that we made were a 2.8 mm microincision cataract surgery, clear corneal incision, all maneuvers made through 2 ports, low flow phacoemulsification parameters, torsional phacoemulsification with intelligent phaco technology, and an altered head position of the patient so as to facilitate easy surgical approach. The patient had an uneventful postoperative recovery, and the first postoperative day best corrected visual acuity was 624, which improved to 612 parts at his 2-month follow-up. Thus, we see that in a quiescent eye with Moran's ulcer presenting for cataract surgery, by doing a pre-operative thorough evaluation, it is possible to anticipate and prepare for the potential challenges during surgery. Customizing the surgery to meet the patient's requirements will help us overcome the hurdles, not only giving us an uneventful surgery but also a satisfactory surgical outcome.